I ignored these prostate warning signs at 50. Don't make the same mistake I did. I want to start with something I do not say often because it is uncomfortable for a physician to admit. I am not just telling you about a patient today. I am telling you about myself. At 50, I had been practicing urology for over a decade. I had explained these exact warning signs to thousands of men. I had drawn the diagrams. I had walked through the mechanisms. I had told patient after patient with complete sincerity that ignoring early urinary symptoms was a mistake that compounds over years. And then I did precisely what I had spent my career warning other men against. I am Dr. John Carter, and today I want to tell you as honestly as I can what I ignored, why I ignored it, what it cost me, and exactly what I want you to do differently if you recognize any part of my story in your own life right now. This is not a comfortable video for me to make, but I think it might be more useful to you than anything purely clinical I could tell you. Because hearing a urologist admit his own denial is different from hearing him describe a textbook. Let me start with what I noticed and chose not to act on. The first sign I ignored, getting up once a night. It started so gradually that I genuinely cannot tell you the exact week it began. Somewhere around 46 or 47, I started waking once most nights to urinate. Not every night, maybe 4 or 5 nights a week. I told myself a story that I now recognize as the single most common rationalization in urology. I told myself it was because I had a glass of water before bed, or because I had a second cup of coffee that afternoon, or because I was sleeping more lightly than usual that week. Every single night, I found an external explanation that had nothing to do with my prostate. Here is what I now know, and what I genuinely should have known then. One nighttime void is considered the upper edge of normal. It is not alarming in isolation, but what I missed entirely was the trajectory. It was not staying at once. Over about 18 months, it crept toward twice. I adjusted my evening habits around it instead of asking what was actually happening underneath. I knew professionally that frequent nighttime urination, what we call nocturia, is one of the most reliable early indicators of benign prostatic hyperplasia. I had told patients that very fact more times than I could count. I simply did not apply it to myself because the version of me getting up at 1 in the morning did not feel like the version of me sitting across the desk from a patient describing symptoms. It felt like an inconvenience, a nuisance, not a signal. The second sign I ignored, a stream that had quietly lost some of its force. This one is harder to describe because the change was so slow that there was no specific morning when I could say, that is different now. It simply was different, gradually, over what was probably 2 or 3 years. I noticed it, in the way you notice something out of the corner of your awareness without ever bringing it into full focus. The stream did not start as quickly as it once had. There was a brief hesitation before flow began. The force was not what it had been a decade earlier. And every time that observation surfaced, I dismissed it with the same phrase. That is just what happens at this age, which is true in the sense that it is common, but common is not the same as something you should ignore. A weakening stream and a hesitancy at initiation are textbook early lower urinary tract symptoms. I knew this. I had diagrammed this exact mechanism for patients, explaining how the enlarging prostate compresses the urethra and progressively narrows the channel. I had used the analogy of a foot slowly closing around a garden hose more times than I could count. I simply never turned that analogy on myself. The third sign I ignored, the sense that I had not quite finished. This is the symptom I think men minimize most aggressively because it does not produce an obvious symptom you can point to. There is no pain. There is no visible problem. There is simply a faint, persistent sense after urinating that something was left unfinished, a residual pressure, a feeling that if you tried again in a minute, something more would come out. I had this sensation intermittently for at least 2 years before I addressed it in any way. And I want to be honest about why I did not address it. It is genuinely difficult to bring up, even to yourself, even when you are a physician who discusses this exact symptom with patients on a weekly basis. There is a strange kind of psychological resistance to fully acknowledging a bodily change that feels connected to aging, to a sense of diminishing capacity in a way that other symptoms do not carry the same weight. Incomplete emptying is one of the most clinically significant early BPH symptoms because it reflects the bladder beginning to lose its ability to fully contract against the increased resistance from the narrowing urethra. Left unaddressed over years, that incomplete emptying becomes a chronic pattern. Residual urine sits in the bladder. The risk of urinary tract infection rises, and the bladder wall itself, working harder against resistance over an extended period, begins the thickening and compensatory changes that make the eventual symptoms more severe and harder to reverse. I knew all of this. I had explained it to patients using almost these exact words. And I still let 2 years pass. The fourth sign I ignored. Urgency that started arriving faster than I expected. Somewhere in my late 40s, I started noticing that the gap between first sensing the need to urinate and feeling like I needed to go right now had compressed. It used to be a long runway. I had time. Then it became shorter. I found myself on a few occasions calculating bathroom proximity before a long meeting or a drive, in a way I had never consciously done before. I told myself this was about hydration, about caffeine, about the specific drink I had at lunch. I built an entire internal narrative of situational explanations rather than recognizing the underlying pattern, which was that my bladder's functional threshold before triggering urgency had been quietly shrinking. This is one of the symptoms I now tell every patient to pay the closest attention to because it is the symptom most likely to be reframed as something else. Anxiety, caffeine sensitivity, a particular food. The truth is usually simpler and less interesting than the explanations we generate. The bladder threshold changes, and it changes because of what is happening in the tissue surrounding it. What finally made me act, and why it took so long. I want to be honest about the moment that actually broke through my own denial, because I think the mechanism by which I finally paid attention is instructive. It was not a single dramatic symptom. It was a conversation with a patient. He was 54, an accountant, and he came in describing almost exactly the pattern I had been quietly living with for 2 years. Once a night, sometimes twice, a weaker stream, the sense of incomplete emptying, some urgency that had crept up on him gradually. I went through my standard explanation, the mechanism of prostatic enlargement compressing the urethra, the progressive nature of the condition, the importance of addressing the contributing lifestyle factors early rather than waiting until symptoms became severe. And as I was speaking, I heard myself, as if from outside my own body, describing my own symptoms back to me through the framework of a clinical explanation I had been delivering to other men for years without applying it to myself. I finished the appointment. I sat alone in my office for several minutes afterward, and I made an appointment with a colleague that same week. The PSA was normal. The digital rectal exam showed mild, symmetric enlargement consistent with early BPH, nothing alarming, nothing that suggested malignancy. But the uroflowmetry study, measuring my actual urinary flow rate, showed a peak flow rate meaningfully below what would be expected for my age, confirming what I had been quietly experiencing and quietly explaining away for roughly 2 years. What it cost me to wait. I want to be precise about this because I do not want to overstate the consequences in a way that produces unnecessary alarm, and I do not want to understate them in a way that minimizes the actual cost of the delay. 2 years of unaddressed mild to moderate BPH did not produce catastrophic damage. I did not develop acute urinary retention. I did not develop kidney compromise. I was, fortunately, in the range of consequences that remained reversible with the right interventions. But 2 years is not nothing. 2 years of mildly fragmented sleep from nocturia is 2 years of measurably reduced deep slow-wave sleep, the sleep stage during which the majority of daily testosterone is produced and during which the anti-inflammatory cytokine activity that should be counterbalancing prostatic inflammation reaches its peak. 2 years of incomplete bladder emptying is 2 years of mild chronic residual urine volume, which is 2 years of low-grade elevated infection risk and 2 years of additional mechanical stress on a bladder wall that was already beginning its compensatory thickening. And perhaps most significantly, 2 years is 2 years of compounding inflammatory and metabolic signaling that I now understand, from the research I have spent years studying and sharing, was actively accelerating the structural progression of my own BPH while I told myself stories about hydration and caffeine. I do not know with certainty how different my prostate health would be today had I addressed this at the first sign rather than the fourth. Medicine does not allow for that kind of clean counterfactual, but I know enough about the biology to say with confidence that the 2-year delay was not neutral. It had a cost, and the cost was entirely avoidable. What I want you to take from my mistake: I am not telling you this story so that you feel reassured that ignoring symptoms is ultimately fine because my outcome was not catastrophic. I am telling you this story because I want you to recognize the exact psychological mechanism that allowed a urologist, a man whose entire professional life was built around understanding this condition, to ignore his own symptoms for 2 years. The mechanism is this: each individual symptom, taken in isolation, is easy to explain away. One night of getting up to urinate is hydration. A slightly weaker stream on one occasion is just tiredness. A moment of urgency is just the coffee. No single data point, viewed alone, demands action. What demands action is the pattern, the trajectory. The fact that these are not isolated incidents, but a consistent and gradually intensifying signal occurring across months and years. If you recognize any combination of what I have described, getting up once or more at night with any regularity, a stream that has noticeably lost force or takes longer to start, a persistent sense of incomplete emptying or urgency that arrives faster than it used to, I want you to do something specific. Not panic, not assume the worst, but stop explaining it away and start tracking it honestly. For the next 2 weeks, keep a simple written record. How many times you wake at night to urinate, on average. Whether your stream feels different from a year ago, and in what specific way. Whether the sense of incomplete emptying is present, and how often. Whether urgency has changed in its intensity or its timing. At the end of 2 weeks, look at what you have written with the same honesty you would want from a patient describing symptoms to you. Do not reframe each item individually. Look at the whole pattern. If the pattern shows any combination of these signs occurring with regularity, schedule an appointment with a urologist. Not because something is necessarily seriously wrong. In the overwhelming majority of cases, including mine, it is not. But because early identification of BPH, at the stage I now know I was at for those 2 years, allows for the kind of intervention, behavioral, dietary, and when appropriate pharmacological, that produces the most meaningful long-term difference in trajectory. I also want to address something directly, because I think it matters for how you interpret what comes next in your own life. The signs I have described, when they occur on their own and develop gradually, are overwhelmingly more likely to represent benign prostatic hyperplasia than anything more serious. But there are specific features that change that calculus and that require more urgent attention regardless of how gradual or mild everything else has felt. Blood in the urine at any point, regardless of how mild your other symptoms have been, requires prompt evaluation. It is not something to monitor alongside everything else. It needs to be assessed directly and soon. A sudden, rapid worsening of symptoms over a period of weeks, rather than the gradual evolution over months or years that I experienced, is a different pattern and deserves more urgent evaluation. Pain, whether in the pelvis, the lower back, or during urination itself, alongside any urinary changes, points toward a different and more time-sensitive process than the slow progression of typical BPH. And complete inability to urinate despite a full and uncomfortable bladder is an emergency, not something to monitor. Go to the emergency room. For the pattern I described in myself, the slow, gradual, multi-year evolution of nocturia, weakened stream, incomplete emptying, and creeping urgency, the appropriate response is not panic. It is simply not denial either. It is the middle path I failed to take for 2 years. Honest acknowledgement, followed by reasonable, unhurried, but prompt evaluation. What I am doing now and what I want you to do, regardless of where you are in this story. Since that appointment, I have implemented essentially everything I now share in these conversations. The post-meal walking, the morning beverage protocol with green tea, tomato juice, and the turmeric preparation, the leg elevation before bed, the pelvic floor practices, the lower body resistance exercise 3 times per week, the dietary adjustments around evening sodium, refined carbohydrates, and alcohol. My nighttime voiding has returned to occasional, not regular. My flow has measurably improved on follow-up testing. My sense of incomplete emptying is, for practical purposes, gone. And my urgency has returned to a normal, unremarkable background level that I do not think about during the day. None of that reversed the mild structural enlargement that was already present when I finally got evaluated. But it stopped the trajectory that those 2 years of ignored signals were quietly accelerating, and it gave me back the daily experience of a body that is not constantly, faintly announcing a problem I had decided not to hear. I am sharing my own story today with all the discomfort that comes from a physician admitting he did exactly what he counsels patients against, because I think the honesty of it might reach you in a way that another clinical explanation would not. We are remarkably good, all of us, doctors included, at building narratives that let us avoid looking directly at something we would rather not see. Do not do what I did. If you recognize any part of this story in your own life right now, take the 2 weeks. Track it honestly. And if the pattern is there, make the appointment. You do not need to wait for a colleague's patient to hold up a mirror to your own symptoms before you decide to act on them. I already know you have everything you need to recognize the signs. The only question left is whether you will act on them sooner than I did. This is Dr. John Carter. I will see you in the next one.